Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I am with Jamie. How are you doing today?
Doing great. Glad to be here, Dennis.
All right. So just jumping into it today, I want to talk about tourniquet conversion. We got conflicts all over the world. Another one just kicked off a day ago in Israel. And I promise you, tourniquets and tourniquet conversion going to be important. So if we could, just starting off, what is the difference between tourniquet conversion and tourniquet replacement?
Yeah, Dennis, this is an important distinction right up front. Conversion is essentially you're making positive efforts either because you controlled hemorrhage or you determined that the tourniquet isn't necessary to actually remove that tourniquet, right? Convert it to some other type of hemorrhage control. That could be a direct pressure dressing. It could be you've achieved vascular hemostasis by surgical means. But in other words, you have found a way to control that bleeding, or the bleeding doesn't need to be controlled with a tourniquet anymore.
Okay. Could that also be you bought a shitty tourniquet from Amazon and it's failing, and now you're replacing it with something that's actually effective?
Sure. Yeah. So replacement. Yeah. So getting to the point of replacement is something's gone wrong with your tourniquet, or you're making an effort to put a tourniquet that's either going to do a better job or save you some tissue. Because again, the mantra under care, under fire is high and tight. And so you're going to have a lot of really strong people putting tourniquets on really high. And those bleeds might be amenable to a tourniquet that's closer in proximity to the actual wound or the source of bleeding. So save your patient some tissue, and you're going to replace that tourniquet with one that's more proximal or closer to the injury.
Yep. Perfect. Just make sure, you have to visualize that injury. It's getting colder now, so people are going to start wearing more and more layers of clothing. Get underneath there, find where the actual injury is, and then just go a couple inches, 2-3 inches above that.
Correct. Great point, Dennis.
Cool. But getting into actual tourniquet conversion, so we've done the care under fire thing. Hopefully we've done some kind of tourniquet replacement where we've gotten it to the skin, a few inches above the injury. Now some time has passed. Hopefully we've gotten the patient away from the X, and now it's time to actually think about conversion. So the guidelines are pretty vague when it comes to that. It says less than 2 hours, or if the operational environment allows, which I got to be honest, when there's gunshots going off or explosions happening in my vicinity, I can constantly justify pushing that longer and longer and longer. Why do I need to? When do I need to convert this tourniquet? Like, he's stopped bleeding. I've essentially saved his life.
Right. So the spirit of the T-TRIC guidelines always goes back to the tactical situation. Are you in an environment where you're creating further risk to yourself and your patient? So implied in your question is we are now in an environment maybe with better lights, better environmental controls where I can really expose the patient. I can see what I'm dealing with. And I've provided for that hemorrhage control by other means. Now's the time to convert that tourniquet. That's what the guidelines are talking about when they say, based on your tactical situation or as the operational situation allows. Really, what I want people to take away is you need to be pushing for that as soon as you have resuscitated that patient. Now, what does that mean? The goals of resuscitation in a patient that's had tourniquets placed for reason of hemorrhage or bleeding and shock is a potential, is your goal is at some point that patient's going to need surgical management, or we want to try and replace that blood loss at a bare minimum. So resuscitation is key. As you're thinking about converting that tourniquet, the very first question you should ask is my patient resuscitated? The answer to those questions lies in is that patient warm and non-coagulopathic? Have you restored volume and the ability to get oxygen to those tissues? If you can answer yes to those questions, which you really should after about 30 minutes. We can go into that in a little bit. But after 30 minutes, you had best be thinking about tourniquet conversion, because after 30 minutes, you probably should have blood products on board. Does that make sense?
It 100% does. What goals for resuscitation? Because, there's kind of the combat ones, like, well, he's got a radial pulse. Is mentating a little bit better than what he was before I gave him, a butt ton of ketamine to control my own heart rate. Or kind of the ICU thing of like, well, his urine output is 30 to 50 an hour. Tissue oxygenation is up, all those, finer endpoints, but on the battlefield, I don't have those. At best I got a manual blood pressure cuff and my fingers. Yeah.
So great. What I love about this is the spirit of looking at the whole patient. So again, implied in this question is you've achieved a security. So you're in a secure environment or a semi-secure environment where you have some time to really assess your patient. What we're looking for is all those measures you just said, Dennis. We're looking for, is the patient still shocky? Do they have poor perfusion? Are they cool and clammy? Are they not mentating well? Well, that's not a resuscitated patient. I'm not going to have time to look at urine output, right? But I can look at their skin, and I'm fairly familiar with my patient's progression by looking at their skin, and that's something I can appreciate over the course of that 30 minutes, hour, 90 minutes. Are they getting better peripheral perfusion better? Ideally, you throw that blood pressure cuff on and you got a systolic above 90. Now, there's a lot of discussion in the guidelines on this. 90, 100, 110 millimeters of mercury for systolic for goals before converting. What I would say is don't get wrapped around the axle on those numbers. This is cutting edge medicine, right? On PFC, we're in an austere environment. Here's why. If you're in a hospital with bright lights and a blood bank, absolutely, those numbers apply to you. But if you're in a field environment where you have very limited blood supply, and you're likely going to be triaging that blood between multiple patients, I just need you to get that patient to a level where they're fairly well resuscitated, where they're survivable, and we're not going to have further bleeding. So you may not get to a full 90 millimeters of mercury, but you've got hemorrhage control. You've got a warm patient who's not coagulopathic. They're not continuing to bleed. Those are really what I want you to think when we think of austere damage control resuscitation. I want to give blood to the point where I've improved the clinical stability and thus survival of my patient. Colonel Shackelford's great publication in JAMA in 2016 reminds us all you got 30 minutes to do that, to get your blood on board for it to really make a difference in mortality. Now, again, that was packed cells in that article, but we do know that sooner is better for whole blood as well, whether that's cold or fresh warm. But bottom line, have that 30 minutes in mind for your resuscitation goal. And then in that next 30 minutes, you best be thinking about converting that tourniquet, because your patient should be fairly resuscitated at that point.
Okay. So the 2-hour mark, I got to be honest, it sounds a little bit arbitrary, like exactly 2 hours. So what is happening? I put the tourniquet on, the bleeding has stopped. Essentially the dangerous part is past, right? Bleeding to death. What is happening, physiologically? Why do they say 2 hours? What's dangerous is building up?
Yeah, so let's talk science on this one, Dennis. Where do we think that 2 hours came from? So first off, a tilt of the hat to John Craig. For those who don't know, this is the father of evidence-based tourniquet medicine. So Dr. Craig, well over 200 publications on tourniquets. And as a standing and voting member of the Committee on Tactical Combat Casualty Care, John took it on as a passion to really provide the medic best evidence and support for what they're doing. the issue here is that a lot of the science on this is hospital-based science. So we looked at orthopedics literature. How long do orthopods have the tourniquet up when they're doing a joint procedure in the operating room? Well, immediately, Dennis, you're thinking, well, gosh, that's an operating room. They've got all the blood, all the resuscitation fluids they need. I mean, that patient's warm. They're controlling everything on that patient, including their breathing. So probably not the best surrogate for us. So when we think about the field environment, what I would rather have folks think about is tissue debt, right? What's the tissue debt we're developing? In other words, what's the body not getting on that tourniqueted extremity that it needs that I'm going to pay for later as a medic? Because you will pay for that at some point. So don't kick your own butt, right? Get that tourniquet down as soon as you can, so you're reducing that metabolic load, the acidosis, the hyperkalemia, the electrolyte abnormalities, all those metabolic waste products that occur in tissue when it's not getting good blood flow. So that's the why. Now, the 2 hours, again, we can go back to World War II literature. And when tourniquets were being used very effectively, Wolf and Atkins is a great Google search. So for the listeners, Google 2 Army surgeons in 1944 or 45 published a case series on their patients that arrived at their surgical facility far forward in northern Italy. And they found that they were able to save limbs up to 6 hours of tourniquet time. Important caveat here. Those patients were cooler because, again, you're in the northern Italian Alps. These patients had longer transport times. And so oftentimes they would arrive with long tourniquet times, but the extremity was cool. Notice I say not frozen, but cool. We are not recommending that people intentionally cool limbs for long tourniquet time. We don't know. That study is yet to be done. I think the Institute of Surgical Research was actually looking at that study. Can we cool limbs to prolong tourniquet time? Until that study happens, 2 hours is absolutely your threshold, because at that point, you're creating metabolic disaster that you don't have the tools to deal with in the field. Sure, keep that tourniquet on for 3, 4, 5 hours, but be prepared for the consequences when you do, because they're going to be big.
Yep. And what I love telling the students, and they hate hearing, you're going to pay for everything you do or fail to do. And correct. So what you've done kind of in haste initially, you're going to pay for later on. So, you sold me. I'm going to convert my tourniquet. How actually do I need to get this done?
Yeah, Dennis, how come you didn't ask me, like, do I do a quarter turn on the windlass every 5 seconds? Yeah. How come this isn't protocolized? Or I have medics ask all the time, well, I heard you need to do a half turn, reassess, do another half turn. And then I've had some medics say, just windlass loose and be prepared and watch the limb and see what happens. What's the right answer?
Yep.
Yes. Yes is the right answer. Anytime we've got that much diversity of opinion in medicine, it tells us that we lack the evidence to really definitively say one way or the other is right. I am not personally aware of any literature that's compared or evaluated, either in a prospective fashion or retrospectively, tourniquet conversion techniques. In other words, what's the best way to take down a tourniquet? We have a lot of case reports of how to do that. And so what I would tell folks is be less worried about the how on the widget and be more worried about your patient. So whichever way you choose to reduce that tourniquet or take it down or take it off, one, look at your patient. Be less worried about what type of tourniquet, how you're doing the tourniquet, how many turns on the windlass. Look at how your patient's doing. Are they resuscitated? Do you have means for primary and alternate control of hemorrhage if they start bleeding again on that extremity? Obviously, you can re-tourniquet it if you want, but that sort of defeats the point of why you're trying to convert and why you're trying to get it off. And then, most importantly, as you take that tourniquet off, be prepared for, especially if tourniquet time's prolonged 2 hours or longer, be prepared for that reperfusion injury, which is all those metabolic waste products getting back to the patient.
Yeah. And I would say just from, experience, those problems that will ensue do not happen quickly. Strangely enough, they seem to take long enough that you start to feel confident about what you've done, and then they start coming in. So being prepared, things like calcium, things like just having more hemorrhage control things available, monitoring that patient constantly. I find that if I have done all those things, then everything seems to go well for me and my patient. But it's the moment that I don't have those things prepared, that's when the badness starts happening.
Yeah, well said. Chance favors the prepared mind, right?
Yeah.
The other thing, Dennis, is we have a huge knowledge canyon or a knowledge divide here. In that, think about how many people are trained to apply tourniquets right now and how confident, right? So there's a huge confidence gap, really, if we want to use a term. It's a confidence gap. We've got a huge portion of our military population that is confident and even eager to throw a tourniquet on. How many people do we have that share that same level of confidence for reducing or converting that tourniquet and taking it off? I would say probably far less. So really, this puts a lot of pressure on our medics and our corpsmen to look at, okay, have I met the parameters? Can I take this tourniquet down? Was it even appropriately placed? You used a great term earlier, hasty, right? Great, throw that hasty tourniquet on, but the implication is there at some point we're going to be not hasty and we're going to be deliberate about our medicine.
Yeah, absolutely. And I would even caveat like the providers that are going to be at the aid stations. If you've trained over 20 years, throw a tourniquet on it, throw a tourniquet on it. That's the patient that's going to arrive. And you're going to have to start doing lots and lots and lots of tourniquet conversions, which are not easy. Not easy at all. And they are all going to require some kind of resources and time management in order to get these things done. So I would caution providers or senior medics or whomever that are doing training, give the training model that is appropriate to do this intervention, not just kind of the whitewash of just throw a tourniquet on it, it's good, move on.
Great point.
Because you're going to pay for that. You're going to pay for that.
That's exactly it. You're stuck with the physiology you've created. Unlike, at the peak of the war and the global war on terror, I could throw as many tourniquets on as I wanted because you know whose problem that was going to be? Somebody in the operation, right? It's going to be the trauma team's problem. And they've got a whole team. They've got bright lights and cold steel to deal with those issues. And all of our patients were in those operating rooms to have those tourniquets taken down in a controlled setting. Well, that may not be the case. And if you're listening to this podcast, that's you, right? Our listeners, folks that won't have the bright lights and cold steel always readily available. So these are great points you're making.
Yeah. So, we extended times on tourniquets. It's going to be inevitable. We're talking about Ukraine, bombardments that are lasting 4 hours, 6 hours until they can get the guy off the X. It's going to happen. Okay. What kind of things, now that I want to do this tourniquet conversion, whether that because I'm receiving a patient, it's been on there for a long time, whether that be operationally, it's taken a long time to get the patient to that place, that we can now do this procedure. What do I need to watch out for?
Yeah, great question. So this is where we have a blending of the science and sort of our expert opinion. And what I would say is, once you get beyond that 4 hour range, we're really on shaky ground when it comes to the literature in terms of recommendations and what you need and what you have to do. I will say as a surrogate, we've looked at rhabdomyolysis, we've looked at other forms of acute kidney injury as it pertains to you're going to open that tourniquet up and you're going to flood the kidneys with some pretty bad stuff. That includes myoglobin from the crushed tissue. So a lot of people ask, well, isn't crush injury just a surrogate for a tourniquet conversion? And when you get out to those 4-6 hour marks, yeah, it probably is, Dennis. And you'll recall early in the days of prolonged field care, that was one of the things we wanted the joint trauma system and the surgical researchers to look at was Well, we're looking at crush because, yeah, crush happens in our population. They get pinned under vehicles and so forth. But we also want to think about it just in case, what if you do have prolonged tourniquet time and it's like that person that's crushed under a collapsed building and is stuck there for 6, 10, 12 hours? I think the big thing is you need to think at this point, number one, is the limb even salvageable at that point? So you need, as the medic and then the patient, need to be medically prepared for the fact and mentally prepared that that limb may not be salvageable once you get in that 4, 6 hour or longer range. And then, of course, going back to what we were talking about, reperfusion injury, when you choose to convert a tourniquet that's been on that long, you're choosing to say, I'm ready for the cardiac. In other words, I don't want to trade a limb problem for a life problem, because I have the potential to cause great harm to this patient taking this tourniquet off at this point because of all the ischemia that's been distal to that device. So if my patient's not resuscitated, and if I don't have some pretty common tools available to me, you mentioned a couple of them, calcium, cardiac monitoring of some sort, and we've minimum better best, right? Minimum might just be a finger pulse ox. Ideally, you've got a cardiac monitor where you can see rhythm and you can see a 12 lead. So you can look for those EKG changes that indicate the heart is not happy with this flood of electrolytes that are coming back. And then further, that ideally you can monitor kidney function and performance to make sure that you're not really causing injury to the kidneys. Last thing we want to do is convert a stable patient with a catastrophic limb injury to an unstable patient who's now got cardiac and kidney and organ effects. Does that make sense?
Yeah, it makes 100% sense. I think two questions come to mind. As much as I want to say, every member of the DoD, everybody that's going to be on the good side of the battlefield are enormous monsters. It's kind of the scale of badness. Our arms have less mass than like our thighs, right? So is there, I have a tourniquet on, the lower half of an extremity because his foot has been crushed or shot or whatever. I've had a long tourniquet time on like a foot or a hand versus a thigh or a bicep, or like, does it matter how much tissue is involved when it comes to the badness that's on the other side of that?
Yeah, sure. I mean, think about that watershed principle, right? Everything distal to that tourniquet is going to be ischemic. The more tissue you have, the more, metabolic waste and byproducts you're going to have. So you're greater risk for a reperfusion injury. What those numbers are and which limbs relative to patient size, I mean, I don't know. I don't think we have definitive published data on that. I'm sure there's some animal study data out there from, surgical research. But what I would really say on this, Dennis, the key point that you're driving at is, are you prepared to deal with that? And then the flip side is, what would happen to our patient population, our soldiers and sailors and all our folks that are fighting, if they knew anytime a tourniquet was applied, they were going to lose the limb, right?
Yeah.
That's not good for morale. So
right.
my bias is always going to be towards try and get that tourniquet off. Let's try and salvage the limb. Let's do the absolute best we can to get distal hemorrhage control and get that tourniquet off and salvage the limb. Let's give that limb the best chance we can while not risking the patient's life. That's about right. That's the art of medicine. And that's why I keep going back to assess your patient. How is your patient doing? Are they going to be able to absorb? For example, if they're pretty touch and go, you barely got that systolic up, they're not maintaining well, they've got a lot of other multi-system trauma, and you've got too high in tights on bilateral thighs, I'm going to proceed with some trepidation on that. Right? I'm going to make sure I'm certainly not going to convert that patient if I haven't resuscitated them. They're warm and they're non-coagulopathic. In other words, they're not oozing from other injuries. If they're doing well otherwise, and I've got a cardiac monitor, or I've got the ability to mitigate some of those effects. In other words, I've maybe got some bicarb, I've got calcium, then I'm going to give it a try, because for the better of our force, we don't want to kill morale and just say, well, hey, anytime you got a tourniquet on, sayonara to the limb.
Yeah. Also, kind of a question in my mind, we talked about salvageable limbs. At no point in time has anybody ever told me what is salvageable and not salvageable. I've seen some pretty messed up extremities that are able to be put, kind of pieced together by, a skilled surgeon. Likewise, I don't want to be the decider in an imperfect situation and have somebody who does have the skill, does have the equipment, does have the time, to turn around and tell me, like, well, you screwed that guy. You should have taken it, you should have done all these other things. Even though I'm in a trench, I'm in the mud, I'm wherever I am, and I've had imperfect information, imperfect patient, imperfect situation, and I've had to make completely life-altering decisions with what I have. So, and maybe you're not the guy for that in-depth of a question, but would you have just any advice as far as what is salvageable and what is not salvageable?
Yeah, Dennis, that's a great point. And I'm sure, I'm thinking back to 20 years of Afghanistan, Iraq, and Syria, and I'm thinking of how many patients we've had with heroic. I'm talking 120 plus units of blood products, or just blood, units of blood, to save a limb. Heroic levels of support that we were able to provide just because that was the only patient or maybe one of 3 patients. So I would say if you have those resources, by all means, yes, try and save those limbs. Convert, give the blood. Maybe you'll have to replace the tourniquet 4 more times until you get them fully resuscitated and they're not bleeding, they're non-coagulopathic. But that's a problem of those who have a lot of resources, right? For those of us that have limited resources, we may only have 4 units or 6 units of cold chain stored whole blood. I've already depleted my walking blood bank. I can't get 6 more units of warm blood into this patient. At that point, it's a typical medic triage decision, and it is a terrible one. Can I continue to give blood products and offer some perfusion to this limb that may or may not survive? And have I got an ability to get hemorrhage control definitively? In other words, stop the bleeding either through surgical means or otherwise. That's a tough one, right? So my answer would be, in an ideal world, you've got enough blood where you can take that tourniquet down, you can see where the bleeding is, the damage to the vasculature, and you can determine whether they're going to have distal arterial flow. And this is just me thinking of this from a non-surgeon perspective. Then that's potentially a salvage. But if I know all of that plumbing is disrupted, they got no pipes left down to the ankle or the foot. Well, and blood goes in and blood just immediately pours out through, all the severed arteries. At that point, even a more junior and less experienced provider is going to say that's probably not a salvageable limb. The problem with what I just said, Dennis, is what? That implies you've got blood available to really test this thing out. This is an unenviable position. It's a tough position for our medics to be in, because really, that's why I go back to what we said at the beginning. Your main job is resuscitate the patient, get them warm and non-coagulopathic. If we can do that, the limb may or may not survive, but either way, not having an extremity is a problem of the living. To quote Andre Kapp, when asked about blood transfusions and getting infectious diseases from blood transfusions, Dr. Kapp has a great quote. He goes, well, you know what? That's a problem of the living, because they're alive to deal with their transfusion-related illness. Same thing here. You're an amputee, but you're alive. I don't mean to be insensitive, because I know that has massive impacts on the quality of life for our folks that are amputees and have suffered through this. But the flip side is, I don't want the medics to walk away doing neither thing well, neither resuscitating nor converting the tourniquet. We always want to make a good faith effort for that, but at a certain point, you got to be able to lay your head down on the pillow at night and say you did everything you could for that patient.
Yeah, absolutely. And I've seen medics with a very difficult decision and have that moment of hesitancy of like, I don't actually know what the right thing is to do, and then when you walk through, well, these are the goals. Have we bought enough room that if we converted that tourniquet and he did bleed, you'd be able to stop it before something catastrophic happens? Yes. Okay. What possibly could happen? Well, this and this and this and this. Like, okay, what are your answers for those things if they were to happen right now? Well, I would do this and I would do this and I would do this. Great. Let's get those things in order. Let's get our monitoring on. Let's assess the situation. If we've bought ourselves some room, is it worth saving that limb? Yes. Okay. Let's get ourselves prepared and let's try it. And unfortunately, that's what it's going to, I think, what it's going to take is buying yourself enough room that if you are wrong, you can salvage, you can save the life. Making sure that you're prepared for the bad things to happen, assuming that they are going to happen, and then taking on the challenges as they arrive.
Yeah, perfectly said, Dennis.
Finally, I got one. So, crush syndrome. Okay, we've got CPGs on it. We go over it and over it and over it again in other podcasts, in other kind of forums. Are there any other things? So, like rebleeding. Can that onslaught of acidosis and other essentially garbage going through the vascular system, can that cause me other problems with my lethal triad or diamond or pentagon or whatever we're calling it now?
Yeah. So let's talk about the most common issues related with reperfusion injury. And I want to focus on those because those are the things that the medics have tools to deal with, right? So that's in the tactical protocols, the medical protocols, and that's things like your calcium gluconate or calcium chloride, right? Chloride's nice because it's smaller volume, 10 mLs instead of 30, same amount, of elemental calcium. But these are tools that you have that you can deal with one of the main problems. And that main problem that'll kill you right there is arrhythmias associated with hyperkalemia. So that's elevated serum potassium. The calcium just helps stabilize that myocardium to prevent those effects from that high potassium. Obviously, we all know if the heart's not beating right and we're adding more insult to injury there, that's going to be a lethal event. And then you're going to proceed down a different algorithm, which is going to be ACLS, and you're going to be coding your patient. So that's a dead right there problem. Now, what I would say is if you're dealing with those tools and you're prepared and you're equipped, great. You got that piece of reperfusion injury. You're alluding to some other stuff, though, Dennis. How is this going to affect my coagulability? Well, again, let's think about that. So potentially you still have viable red blood cells and platelets there that now have shifted their hemoglobin dissociation curve, right? That oxygen dissociation curve. And I realize I'm giving people bad memories as they think about biochem and jam and all that stuff in their head for their exams. But we don't know is the bottom line. We don't know, especially depending on the watershed. So what's the area of tissue that's how that's going to impact that patient once you release that tourniquet. What I would say is plan. That's why you want to warm non-coagulopathic, so they shouldn't be oozing from any non-tourniqueted injuries before you're converting. If you still choose, you can still choose to convert, right? So you can still take that tourniquet down, even if they're oozing elsewhere, but be prepared, right? You better have a mechanical means for control other than that tourniquet. For example, are you going to use forceps to ligate a vessel? That type of radical thinking, because you're not going to make their coagulopathy any better by reducing that tourniquet.
Yeah. Right.
I don't know that we have a timeline or a specific standard, or there's evidence to show, you can expect a 30% reduction in clot stability if a eye is tourniqueted. We don't have that data. If we do, and again, that would be a great study to look at some point, I think we'd find that there's pretty significant impairment in the coagulation cascade.
Yeah, absolutely. And as much as I would love to have the data, I have no actual way to measure it. So
Correct.
you're going to have to take it as it comes and understand these things could happen. One, do you have more blood available? Can you get it? You know, they're going to have to deal with that. Their body is going to have to deal with that acidosis. Can you help them? And essentially constantly monitor, constantly assess, and kind of limp this patient along until their body can take over.
Yeah, great point, Dennis. And you get into a fantastic point right there with the acidosis, right? So I may not be able to do much about the coagulation cascade outside of giving blood, right? Blood is the answer. But what can I do about acidosis? So that is something that the medic has other tools in their toolkit. And I think you're alluding to this. That's, our sodium bicarb, 50 mil equivalents that's available in those standard sodium bicarb ampules. 3 of those suckers mixed in your standard bag of saline gives you a little bit of a hyperosmolar solution. And we believe if they are having, because here's the surrogate issue. Like, I don't have a study showing that for tourniquet reduction, that protects the kidneys. We haven't done that study. But we've done it with a lot of other nephrotoxic, in other words, bad for your kidneys types of things. That can be daptomycin. There's an old 2006 publication that showed the effect of protection on the kidneys from alkalinization. Sorry, hard word to say. Reversing the acidosis with bicarb from the renal insult of a bad toxic drug for kidneys, daptomycin. There's other studies. Most recently, 2018, Lancet published the bicar ICU study. So the bicar ICU study looked at in patients with acute renal injury that are very sick, most of them on ventilators, who had a metabolic component. So this isn't respiratory acidosis, it's metabolic acidosis, sepsis most often. Was there a benefit in mortality or a reduction in end organ injury in those patients when they received sodium bicarb? That study showed no benefit in mortality. Okay, didn't change living or dying. Now, keep in mind, these are sick patients. What it did show was a benefit in end impact on the kidneys for those patients that had acute kidney injury. So when we think about our shock patient on the battlefield who's had a tourniquet applied, and then we're going to take that tourniquet down and jam them with a bunch of myoglobin, broken down muscle tissue and cells, that myoglobin component is the renal toxic component. I think we can imply, again, there's no definitive data to say this, but the bicar ICU trial gives us sound footing as a medic to stand on and say, man, if I've had a long tourniquet time on a thigh, an area where there's going to be a ton of myoglobin, or they've already got Coca-Cola urine, they're peeing that dark brown pigmented urine, you're probably on safe scientific footing giving them bicarb to alkalinize.
Yep. No, it makes sense. And I mean, I've heard bicarb as far as mentioned being used a lot. What is the downside? I give them some bicarb and nothing happens.
Yeah. So remember, first do no harm. So anytime we're throwing a drug, we got to know what the potential adverse events are. There are, and I challenge all of our look at that. If you're a little overzealous with your bicarb, or again, you're not monitoring that infusion rate. Remember what I just said, that's a hyperosmolar concentration you're pushing into the patient. So that's going to take volume from cells and put it into the intravascular volume. You're probably going to get a transient rise in blood pressure, which again, if you don't have your hemorrhage controlled and your patient's not resuscitated, that's a problem, right? Because you're potentially going to, I hate using that term, pop the clots kind of thing, but there is in theory a potential for that. There are also some well-known side effects from overzealous use of bicarb. And finally, what I'd say is a lot of our young, healthy battlefield casualties are going to be compensating on their own via respiratory means, right? So their body is already adjusting their pH for a metabolic acidosis by using their own breathing to off-gas that CO2 and reduce their own acidemia. So in theory, there's a chance, depending upon when you administer the bicarb, of interfering with their own natural homeostasis to try and restore their acid-base balance. But it's a great question. I'd love to delve more into that and just really look at what are the harms with bicarb. But again, nothing for free. You don't get anything for free. You're going to have a definitive impact on their physiology. You just need to be mindful of that.
I had one other question more relating to the crush CPG, but since this is tying in and out of that as well, it mentions using 1 gram of calcium, and then it doesn't really delve into that 10 mLs of calcium chloride, or is that the 30 mLs of calcium gluconate, which if you read the labels, that's actually 3 grams of calcium. Which one do you want? I'll do any of them. Just tell me which one you want.
Which one we want, yeah. Well, I think from a practical perspective, a lot of the concerns with calcium chloride were the irritability of the infusion site, right? So again, we're thinking about, we're not infusing this through a tiny little vein, with a 25 gauge. We're leaking it in, and it's just sitting there in the vein. These are going to be trauma patients. These are patients with fairly large volume catheter infusions going. So let's take that theoretic risk, the irritability and vessel damage off the table with chloride. Those are real concerns with calcium chloride. But in our setting where we're really looking at big infusion in a trauma patient, I think those concerns are overstated, and that's been put to bed. So for bang for your buck for elemental calcium, 10 mLs versus 30, right? Now the TMAP says, right, the old version of the TMAP says do 10 mLs of calcium gluconate, not chloride. Chloride, we got it. 1 gram is 10 mLs of calcium chloride. Now let's switch to calcium gluconate. So that comes in a 30 ml dosing vial, like you said, Dennis. And then the TMAPS tells us just do 10 ml infusion of that. So the implied task is exactly like you said. That gives you the equivalent of 1 gram. This point, I don't know. I'd need to go look at those labels and say definitively for sure. Yeah. I've always been translating it in my head, and you might have just caught me. It could be wrong. I've been thinking 30 mLs is the 1 gram equivalent. But let's check the labels on that one and post that in the show notes.
So I know label-wise, just what I have available to me. 10 mLs of calcium chloride, 1 gram. I also get 10 ml vials of calcium gluconate, which say 1 gram, or you can get 30 ml vials of calcium gluconate, which will give you actually 3 grams. You know what I mean? And it's confusing. And
that's confusing. Yep. So great principle here, Dennis, always read the label, right?
Yes,
so
absolutely.
We write protocols, and sometimes the protocols don't catch up with manufacturer packaging or what the latest vial is. Gosh, remember in the early days of TXA? Remember it came in that glass ampule, so you, in theory, had to have a filtered needle, right, to draw that because it's an ampule. Well, gosh, it wasn't until 4 or 5 years after everybody was using TXA that we started putting it in a plastic vial where you could just draw it normal. Remember that?
Yeah. Yes.
So there's
sadly, I do.
Yep. So there's a great example of how the packaging is changing. So this is, again, implied task. Get to know your friendly medical logistics folks or your supply, and take a look at your labels and then run that by your medical director. As with all things on our podcast, Dennis, all of this is subject to your medical direction and your chain of command. Make sure you're running all this by them. Our hope on this podcast is to continue the conversation, get people to think about alternative methods. But at the end of the day, this still falls under your licensed prescribers to dictate.
Yeah. One last question about calcium. Let's say I have just the 10 ml vials of calcium gluconate. Okay.
Mm-hmm.
I give said vial to my patient. I'm monitoring him. I have my little, cardiac monitor. It's a 1 lead. I'm trying to do all the things to the best of my ability. It doesn't necessarily work, or I'm not seeing it change from what it was before I converted the tourniquet to back to I was watching it. It was normal. I converted. It's now abnormal. That one 10 ml vial did not push it back to normal. How fast do I need to respond to send more calcium?
Yeah, so this also a great area evolving in the studies and the trauma literature, right, Dennis? I think, the answer to this question would have been different 5 years ago, but now that we're, like you were talking about, the lethal pentat or the lethal diamond and including hypocalcemia in that, this was actually discussed at a tactical combat casualty care meeting. Is there really harm in giving calcium to the hemorrhagic shock trauma patient? And the answer generally was no, because we know these patients are typically hypocalcemic upon point of entry to the healthcare system, just due to blood loss and all the coagulation stuff that's going on. So my answer to that would be, I think you'd be on safe ground as a medic to pretty quickly follow that with a second dose of calcium. Again, depending on your patient's condition. What do you think their total blood loss was? Is this a class 3 hemorrhagic shock patient who has massive vitals abnormalities before you started your perfusion? Absolutely. That's a patient I would be thinking about giving 2 or 3 grams of calcium right up front, because you're going there with your blood replacement. You're going to give that blood, and you've already got good protocols saying, hey, after that first unit of blood or with the first unit of blood, get that calcium going. So you're going to be resuscitating these patients. They're getting blood, so you're on safe ground for multiple serial doses of calcium.
Yep. Perfect. If you had to give any advice to a young medic going into harm's way when it comes to tourniquet conversion, what advice would you give him or her?
Convert, right? If you're in a setting tactically where you're no longer under fire, you're doing tactical field care, resuscitate and convert. I think, Dennis, we've hit that today, why that's so important, both for morale, for the patient's long-term morbidity. There are so many reasons to try and convert, and that's why this podcast is so important. It's that experience and confidence gap we've got right now. Everybody's good at throwing these things on. Not a lot of people are good or confident, at least, at taking them off, taking the tourniquet off. So my challenge and my recommendation to the medics would be prepared, get your equipment, get your hemorrhage control measures, everything ready, and try and convert. Can you imagine a world where every single tourniquet we put on resulted in a lost limb? That's a bad state.
Yeah, that's a bad state.
Right. So my thought, I know this is a hard part of the medic's job, right? Because they're making a life limb decision. But my challenge to you is be bold, because you want to be able to sleep with yourself after and rest, right? Knowing you've done everything you can for that patient. You lose very little other than a little bit of blood. If you're minding your P's and Q's and you're on your game, you lose very little from attempting to convert. You lose a limb at a minimum if you don't, and potentially a life if you convert too late.
Cool. Thank you very much, Jamie. I love being able to chat with you whenever I can.
Thanks, Dennis. Great job on the podcast. Keep it up.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast. Out.